and welcome to our Patient-Centered Medical Home, or PCMH, Transformation Panel. Our purpose is to examine the PCMH transformation process through the administrative lens. We have 5 panelists from across the state of Idaho with us here today, each with their various responsibilities in transforming their healthcare settings into the patient-centered model. We'd like to share key dimensions of administrative perspectives and give you some ideas about navigating your healthcare settings transformation as well. Thank you for joining us. So there's a popular phrase in healthcare, the triple aim, which by that we mean improving patient experience, improving population health overall, and lowering the costs. But we're also looking at that quadruple aim where we're, like Michael said, improving the culture and the perspective of providers and other staff, improving their experiences as well. What's the culture been like in this transformation?
So I'll start with that one. When we first started on this journey, we quite frankly had a pretty high turnover in staff. Because you either really like this model or you don't like this model and want to go someplace else. And so I think expecting that might happen for someone that's just starting out on the journey, really understanding that it's okay. You know, if this isn't your thing and you want to go do something else, that might be beneficial for both you and us. And so really understanding that and being okay with that. And now the folks that are there, we don't even call it PCMH anymore. It just is the culture. It just is the way that we do things at Terry Riley, and everybody knows the expectations. And now we have very long-standing providers, and they love doing what they do and being able to have the whole team helping with each of the patients.
So it's been worth it for everyone, sounds
I
like.
think it's been worth it for everyone.
Mm-hmm. I think everyone's heard of compassion fatigue. I like to say that a lot of our providers had regulation fatigue. And
well stated.
And so this, resistance that we were talking about, we definitely experienced that and still experience that from time to time. But it's gotten better. And we're actually seeing how the PCMH practices are reducing that regulation and instead of increasing it. And so as an FQHC, we have a lot of reporting requirements, and we're participating in meaningful use. And when we said PCMH, they just cringed, and we're scared of what that meant to them. And now I think they're really starting to be able to see the benefits, where I don't feel as rushed anymore, and I have more time to maybe deal with all these other regulations because I can utilize members of my team to help me through this patient experience. So the patient comes out of every encounter still feeling like they got all the attention they needed, even if it wasn't directly from their provider, it was from the nurse, it was from the care manager, it was from somebody doing an SBIRT. And so the patient leaves happy and the provider feels relieved, and I think that everybody's starting to feel less fatigued.
Great.
For us, the transformation is still ongoing, and so we're still seeing kind of the shakeout of how this is affecting people. The initial feeling of it was here's another acronym that we've got to comply with. And I helped track meaningful use in PQRS and now MIPS for our organization, and so the initial feeling was here's yet another thing that gets in the way of us delivering care, and we have to check all these side requirements and things, and so we've had to do a lot of work to show that the intention of this and the reason why it isn't the government pushing us to do this. It isn't, there might be some payment model. You talked about ACOs. There might be some payment models that might push you towards this, but there wasn't anything that we were facing that was forcing us to do this. We were electively choosing to do this because of the results that we felt it would have on how patients experience, getting care with us. And so in working with some of our providers, we've had to show that like the intention of this is just to make things better for everybody. And so we've had to take some kind of tangential projects that weren't directly related with, you know, a certain PCMH requirement, but we're in the spirit of quality improvement to show like we're wanting to make things better for your patients and better for you and better for your staff. And so the evolution over time has been that like this is different. This isn't meaningful use. This isn't something else. This is something that the core of it is to make us better and to make us work together better as an organization. So that's been kind of a key culture change. The other thing too is you know, separate from the providers with our staff, the feeling has changed from, instead of just being subservient to, you know, I do what the provider says, I do the same things every day, and you know, whether I like them or not, it's what I do, and I just do what I'm told, and you know, get through the day. Now it's I have some ownership over how things go in the clinic. You know, maybe I'm not the provider or the clinic manager, but I have some ownership over Jane's experience that's coming in today. And so whether that's participating in the huddle and you know, bringing up a point or checking on something on Jane's behalf that helps make her visit better, or you know, we as a clinic want to do better at colonoscopy screenings or mammograms or, you know, any other quality improvement project you could bring up. We've done some things to help our staff feel like that they have a role to play in that, and they're not just there doing the same thing every day and dealing with the limitations of the EMR that we have and just, you know, just taking it, but that we can make changes and tackle things and improve things for their behalf, and they can be involved in that.
So not only a financial cost benefit analysis, but also provider and staff relationship to what's in it for me is what I'm hearing you say. Yeah. Rachel, Stephanie?
I think anybody here in the Treasure Valley is probably familiar with what happened with Salzer's history in the last couple of years. So we're accustomed to change, and I think we're exhausted. And so I think even mentioning that, hey, I just need to sign one extra thing, and then it becomes like any small task. So it's becoming, we have to be acutely aware of the workload. So I went and sat with all of our front office staff, and I wanted to get firsthand, what are your barriers, what are your obstacles, what are difficulties, and then what's something I can take off of your plate in order to kind of shift this in here, or I can show you shortcuts. And then I think also that the shift more towards like a shared decision making with patients, and we want to empower them more to make those decisions and not always call the nurse or doctor every time, you know, that that's inappropriate to not have to call them, but not necessarily just to take their word for everything. That go out and do your research and talk to other people. So just kind of giving them the autonomy to kind of help make those decisions and become more informed patients is a shift that we're hoping to make. Yeah.
Awesome. Is this part of the camp?
That's part of a new checkbox.
There we go. Well, it needs to be. 'Cause that feels pretty good.
I would like to second some comments that have come up. I think this transformation has really not only allowed staff to see their true value, it really has kind of, I think, brought more to the forefront to all of the clinic how much these support staff members really do. I think oftentimes providers can take that for granted. Mm-hmm. And I think PCMH has allowed them to see, you know, our colorectal cancer screening rates, like I've almost tripled in 3 years, our depression screening rates, all of these different things that we didn't even really touch on a few years ago are getting done, and they're getting done by a very committed and focused support staff that is huddling, that is indicating who needs what. They're identifying treatment opportunities. Everything's ready, so the doctor just comes in and says, okay, they're going to take care of you, and you know, they're there for what they came for, and then they're getting all these extra services as well. It really has, I think, allowed us to embrace also our role in educating patients and getting them engaged, which I think is kind of where you were going, is setting self-management goals, really checking in with them. Okay, what are you doing to improve your care? A lot of times I think we take it upon ourselves that we have to do everything to make them healthy, and we really don't. We need to just educate and empower them as well. So that has been a big part of that, and our providers really are seeing that. I think we'll see more of controlled disease populations over the next year, because we've been doing these very targeted interventions. We've been doing the self-referral reporting. We've been doing all kinds of different programs that at the onset seemed like so much work and are now just a part of the regular workflow. They've just taken it in. And it's just part of what they do. And so I think we're really going to start to see the effects of that over the next year with more controlled diabetics, more controlled hypertension, less severe depression in our patients, because they're being identified early and getting an intervention or a medication early on. So that has been a huge benefit. We have had providers who, like I've mentioned, were very resistant, and through the PCMH transformation, but also through the SHIP coaching that we've had available for them. They've changed they've done 360s here. They've just completely come back and said, this is really great. I love that I get into the office and I know exactly what my patient is here for, but I also know what they need, and I know exactly what to tell them to come back for. It's been a huge benefit for our providers as well. So I think and also, it's pretty much everywhere. I mean, it's in UDS reporting, it's in meaningful use, it's in almost every grant application that you see, wants to see collaboration, care coordination, wants to see team-based care. So it's pretty, PCMH, the fundamental ideas behind PCMH have pretty much integrated themselves into, I think, almost every aspect of the healthcare delivery mechanism today. So it's the way to go.
And so it seems like you're saying that there's a lot more collaboration, not just inside the office, but also collaboration with the patient as part of that care team. Would that be an accurate reflection?
Right.
Yeah.
And I think honestly, it needs to be provider driven, and it's, I hate to put it on one person's shoulders, but without that provider buy-in, you're not going to get the provider or the buy-in from the staff first, and then you're not going to get it from the patient if there's not that support for, hey, I want to see you back in 6 months for your wellness visit. That if they don't make it a priority and they don't reiterate the importance to the patient's going to be like, meh.
Yeah. Do you guys see that as you transform, that the patient themselves kind of has to in that participation piece?
I hope so.
Definitely. Yeah. I think they appreciate the efficiency that we're showing them as well. As Bethany stated, it's difficult for a lot of our patients to travel into the clinic, and with all of the outreach and the preparation, we're getting a lot more efficient and effective and doing a lot more with every touch that we have with the patient. And so we're getting, I think that they appreciate that.
Great. So the last thing that I want to touch base on is, what do you know now? As you look back and you know this thing now, this nugget of golden information, what would you pick out of all those things, all those points of knowledge and wisdom, that you would have known that at the beginning instead of where you're at today?
One of the things, because we started so early on this journey, is it really wasn't a journey back then. It was seen as a project to do. We're going to hire somebody to do PCMH. It's a project. We'll get it done and we'll move on. And it's not. It is a journey that will not, and you keep getting better and better at what you do. You keep finding things that you didn't think of, such as social determinants of health and how do we integrate that. We did the dental integration, which we had not even thought of when we first started this journey. But really understanding now, it's not a project. This is the way you're going to do business going forward.
It's a lifestyle change.
Yeah, it is. Yeah.